looking forward to all of our panelists today. So I just want to thank everybody for coming and joining us for the panel discussion today at ESMO 2021 Melanoma Abstracts. My name is Jen Margellis. I am the project owner handling all of our clinical panel series at LARVOL. And I want to take this opportunity to thank our wonderful panel of speakers today. We have our moderator, Dr. Diwakar Davar. Dr. Davar is a medical oncologist and hematologist, assistant professor of phase 1 therapeutics and melanoma at the University of Pittsburgh, UPMH Hillman Cancer Center. And our panelists are Dr. Pauline Funchain. She's the director of melanoma medical oncology and the director of genomics at the Tausig Cancer Institute in Cleveland Clinic. I hope I pronounced that correctly. And we also have Dr. Jennifer McQuade, melanoma medical oncologist and assistant professor in the Department of Melanoma Medical Oncology in the Division of Cancer Medicine. Dr. McQuade is at the University of Texas at the MD Anderson Cancer Center. So thank you to all our panelists and to our audience for being here. We're really excited to hear from you as you discuss the impact of these melanoma abstracts from the recent ESMO conference. So with that, I will hand it over to Dr. Davar.
So thank you for the kind invitation to speak and to moderate this session along with my wonderful colleagues, Dr. Funchain and Dr. McQuade. So we'll start off with the recently presented data of relativity 047. So without missing a beat, Pauline, do you want to tell us a little bit about relativity 047 and what do you think about this nivo-rela combination?
Yeah, so this is an update. We heard about this trial at ASCO, and as a short reminder, so relativity 047 looked at the combination of relatlimab, a LAG-3 blocking antibody with nivolumab versus nivolumab monotherapy. At ASCO, we heard a statistically significant difference in PFS with the combination arm having a PFS of 10 months, and then nivo monotherapy 4.6 months. And this abstract gives us a little flavor of what happens after therapy and what the sort of the long-term effects of a combination LAG-3 PD-1 versus monotherapy PD-1 might look like. And so they look at two measurements. One is treatment-free interval. So after treatment therapy on trial, what was the median time to subsequent therapy? And that for the combination is 3.2 months, which is statistically different from the monotherapy, which is 1.4 months. And then they look at a measure called PFS2. So PFS2 looks from the time of randomization to the time off subsequent therapy or to death. And you can see here, so it's a sort of a combination of both the effect of the first line therapy and also the second line therapy. And if you look, the median PFS2 is not reached for the combination arm versus 20 months for the monotherapy arm, and that's statistically significant. So first of all, I have to say, I'm happy to see us looking at long-term effects. I think it is a little hard to tell, let's say for PFS2, what is first line versus what is second line, but at the same time, I think we are all getting the sense that immunotherapy is not just the time they're on trial, but what sort of the immune system has learned in the time you've put them on that immunotherapy drug or drugs. So to look long-term, I think is where we need to go as a field. And I really do like seeing these data. You know, I think from ASCO, we already feel that this combination may be in first line, the new standard of care, and seeing the sort of long-term benefits, potential benefits, I think just confirm that sense we got from ASCO.
That's perfect. So let me maybe ask a question. So you feel like this is clearly practice changing. Is there a patient population that you would not treat with Nivo-Rela? And if so, what are those patient population or populations?
You know, that's a good question. To me, combination therapy versus monotherapy, there's not a whole lot that differentiates them. Most of the time when we're thinking about combination versus monotherapy, we're actually thinking more about potential AEs. And I don't think that I have a good sense that LAG-3 is different than PD-1, and there's some population that's different. So I don't know that offhand I can think of a specific population that I might not treat with combination therapy here. And the AEs that were reported previously looked like they were significantly less than Ipi-Nivo, right? So, I mean, if the question is this combination versus Ipi-Nivo, that's a whole different story. But if you're talking about is there somebody I would choose Nivo versus this combination, I can't think of the difference.
So it sounds like based on this that it is highly unlikely that many people, and I think I completely agree with this sentiment, that there's likely to be a practice paradigm shift over the next couple of months in the direction of at least Nivo-Rela as a combination. But you brought up a very interesting and provocative question, which is what is the future of our, at least up until this time, our prescribed combination therapy, which is the combination of ipilimumab and nivolumab, now all of 6 years in history. So what do you think is the future of Ipi-Nivo, or is there a future of Ipi-Nivo?
I think that there is still a place for Ipi-Nivo, particularly Ipi-3, Nivo-1. Brain mets, I think, are going to be a place where we will still use that. You know, I don't have a sense yet whether there might be, you know, a high burden of disease. I think liver mets, I'm still really leaning on Ipi-Nivo. I also think we don't yet know about BRAF mutation status in this trial, but I think that we've seen that BRAF mutant patients do benefit from Ipi-Nivo. So I would lean a little bit more there.
Okay. And do you have any advice for all those clinical trials out there that still have PD-1 as the control arm?
Right. You know, once you've started, it's too late. But I think going forward, Rela plus Nivo is going to end up having to be the comparator arm.
All right. So that I think there was a question in the audience from Dr. Hashim Yunus, and his question was, you know, is PD-1 monotherapy dead in metastatic melanoma? So without being quite so dire, I think Dr. Funchain has clearly answered the question that it's highly unlikely that many people are going to be sticking with PD-1 monotherapy, even in the highly symptomatic patient populations, given the relative tolerability of the Nivo-Rela data. One other question, I guess, Dr. Funchain, thinking ahead to the other treatment paradigms in which you expect Nivo-Rela to migrate into, what are your thoughts on think that this is going to be a possible combination in the adjuvant setting, for example, especially given the in light of the Checkmate 915 data, the particularly negative Checkmate 915 data?
You know, I think it's going to be interesting. I think the adjuvant setting is so challenging in that you get diminishing returns, I think, with every step down in terms of stage, and it makes sense. It's a statistical effect, right? If you're less likely to recur, then there's a smaller proportion of people that you're treating where there's activity. So, but I think, you know, Rela plus Nivo may have a place because, you know, I'm still not convinced about Ipi-Nivo in the adjuvant, neoadjuvant setting. And I think that a large part of that is a question about toxicity in stages where there may have been surgical cure. I think though, with the AE numbers that have been coming out of the Rela-Nivo trials, I think that's an easier pill to swallow if we do end up seeing effect in those settings.
Perfect. So I think we'll now switch to Dr. McQuade, who's going to tell us a little bit about the pembrolizumab versus placebo trial that was conducted by Merck in collaboration with my colleague and close friend, Dr. Jason Luke, and many other colleagues. So Dr. McQuade, keynote 716, please.
Sure. So Keynote 716 is actually looking at adjuvant pembrolizumab versus placebo in high-risk stage 2 melanoma. And this is actually a double-blind phase 3 trial. This is exciting data, and I think we have to start with the question of why look in high-risk stage 2 melanoma, and what does that mean? So high-risk stage 2 are basically patients with thick or ulcerated primaries. And we know from AJCC 8 that these patients actually have worse outcomes, melanoma-specific survival, than patients with 3A, and nearly equivocal outcomes actually to those with 3B. And so we, of course, have adjuvant immunotherapy approved in stage 3. And so the question now is, given their poor overall melanoma-specific survival, can we now move adjuvant immunotherapy into the high-risk stage 2? So here they actually randomized 976 patients between pembrolizumab or placebo. And this is a really early look at 1 year, and they have already met the primary endpoint of an improvement in recurrence-free survival with a hazard ratio of 0.65 and highly statistically significant. So P equals 0.007. The rate of relapse-free survival at 12 months is 91% in the pembro arm versus 83% in the placebo arm. They did do our standard forest plot where they look across subgroups. It does seem that we get benefit across the different subgroups, noting that T4B, for whatever reason, appears to get less benefit, but again, with caution that this was not a predefined analysis and not powered to look between T stages. And of course, when we're looking at stage 2 and adjuvant, and Pauline already alluded to this, in the adjuvant setting in general, we really have to think carefully about our risk-benefit ratio and around toxicity. And so here, the rate of grade 3, grade 4 adverse events was 16%. Most of those are hormonal, so hypothyroidism and hyperthyroidism. All told, there were actually about 18% of patients that end up on long-term hormonal replacement in this study. So it is something to take into consideration when we're talking about risks and benefits here.
So thank you for that wonderful summary. So it sounds like you believe that this is going to, if successful, probably, which it likely will be, I guess, you're likely to be offering this to your patients in the next couple of months.
Yeah, I think that this is a practice-changing study in that we will be offering it to these patients. Now, the question is, should all patients with stage 2 melanoma choose to have adjuvant therapy? And that the jury is still out. And I think it's really comes down to, to shared decision-making. I will note that we lack overall survival data still here. And even in the stage 3 setting, right, that question of now versus later is still a bit unclear. And, some of this comes down to really to kind of patient preference and risk tolerance.
How do you feel like this is going to affect, for example, the concurrently enrolling, but now since close to accrual, Checkmate 716 study? So we've got Checkmate 716 with nivolumab versus placebo, Keynote 716 with pembro versus placebo, do you feel like if these two studies are both become positive, that the question will shift to duration of therapy rather than whether or not to treat? Or do you think that the duration and choice of treatment versus no treatment are still open-ended questions?
Yeah, I mean, I think that the duration of treatment, we still haven't gotten that even in a stage 4 setting. And the question with these types of studies, you know, around duration or around de-escalation of therapy really is, are the pharmaceutical companies going to have the appetite to pay for that study? So they're great questions. I think that clinically what we do is we just have a very low threshold to discontinue treatment in this setting with any type of toxicity. But again, 1 year adjuvant therapy is arbitrary across stages and really across cancers.
Yeah, I completely agree with you. I think the only trial that ever tested duration was actually a trial done by ECOG that looked at 1 month versus 1 year. And that was in the days of interferon, long since past. So this is, I guess, going to be something that is going to be a question that we all think about going forward. One related question to you would be, would you hazard to comment on what, you know, clearly this, for example, assumes complete surgical staging, right? So one of the key things to keep in mind is that the role of stage 2 therapy is only defined in the context of adequately treated stage 2 patients. However, we do know that a certain proportion of patients undergo non-surgical staging. For example, staging with Mohs surgery, for example, an area that, you know, is still something that is relatively controversial in the context of melanoma therapy. In light of this, how do you feel like those treatment decisions should be made? Do you think that this favors direction in favor of surgical staging, or do you think that this should apply regardless?
Yeah, no, it's a great question, because really, if regardless of what the sentinel node shows, you're going to be offering adjuvant immunotherapy, and given that, again, we know that that outcomes really aren't different for high risk stage 2 than with sentinel lymph node detected melanoma, then it does take away a bit of that potential need for the sentinel node biopsy, because you know that these patients are eligible for adjuvant therapy if this is approved. Now, whether it still has prognostic benefit, I think is certainly possible. And I think I would imagine that we would still do a lot of sentinel lymph node biopsies for that reason, but it won't be as necessary for treatment decisions.
Okay. At this point in time, in terms of the relative cost-benefit ratio, you know, we still have never really asked and answered the question of cost. There are approximately 2 times as many stage 3 patients as they are stage 4 patients, and 3 times as many stage 2 patients as they are stage 4 patients. So we're now talking about a treatment decision that is potentially going to affect between 30 to 40,000 patients a year in the United States.
Yeah.
Do you have trouble sleeping at night because of that?
Yeah. I mean, again, this is one of those, there's another study that has the potential to bankrupt our system. This, you know, a year of treatment with these immunotherapies is extraordinarily expensive. And that's even if we don't end up with, you know, with toxicities requiring hospitalizations. So it's a big issue.
Okay. So at this point in time, we will transition to Checkmate 204, a study that was done and led entirely by a group of physicians in the cytokine working group, and one of Dr. McQuade's colleagues, Dr. Hussein Tawbi, formerly from Pittsburgh and now proudly of MD Anderson's fame. So Checkmate 204, the 3-year data of ipi/nivo in melanoma brain mets. So what was this trial? So melanoma brain mets, right? Essentially, 1/3 of patients with melanoma have advanced brain mets at the times of diagnosis. That's 75% of the time of death. Historically, a marker of poor survival in historical series. A small fraction of these patients, when treated with, you know, adjuvant or pseudoadjuvant therapy or immunotherapy or targeted therapy, did have long-term PFS. And single-agent targeted therapy and immunotherapy, both with anti-PD-1 and CTLA-4, had intracranial activity. So Dr. Tabi's study was essentially a randomized phase 2 that evaluated IPI-3-NIVO1, so the IPI-NIVO combination of Checkmate 067 fame in both symptomatic and asymptomatic advanced metastatic melanoma with intracranial metastases. The data regarding the asymptomatic brain mets was published in 2018 in the New England Journal, and the symptomatic paper was published earlier this year in the Journal of Neuro-Oncology. And essentially, the treatment duration was the standard 067 regimen of 24 months of IPI-3-NIVO1. The primary endpoints were intracranial benefit rate, or basically CR, PR, and ST greater than 6 months, using CNS criteria. The secondary endpoints included extracranial or systemic benefit, as well as global clinical benefit. That was the aggregate intra plus extra benefit rate. In 2018, at a median follow-up time of 14 months, the reported intracranial benefit rate was 57%, which included 26% CRs, 30% PRs, and SD rate of 2%. And the extracranial benefit rate was a highly commensurate 56%. The grade 3 and grade 4 adverse event rate was 55%. Basically, intracranial, extracranial, and systemic benefit rates were largely similar. At ESMO now, we see the 3-year data from this combination. The 2-year extracranial disease rates were 59% and 62% for investigator and BICR. And the 3-year rates were highly commensurate, 53 and 62%. What is very interesting is that the 3-year PFS rates were actually greater estimated by intracranial review that was blinded as opposed to investigator-assessed response. The commensurate global rates were highly similar. Again, 50% and 48% for investigator-assessed and BICR, and 45% and 48% at 3 years for investigator-assessed and blinded review. It is, again, highly reassuring to note that these rates are comparable to the IPI-NIVO arm of the ABC trial, as was reported by Georgina Long. She reported a 46% intracranial 3-year rate at ASCO in 2021, 3 months ago. And this study is clearly underscoring the benefit that we see systemically with disease in the brain. So again, for me, this was a very, very a significant data set. And I do want to get my colleagues' thoughts on how they felt about it as well. So Dr. McQuade and Dr. Funchain, are you guys as excited about this as I am? Dr. McQuade.
Yeah, no, absolutely. I mean, I think from the very beginning, a couple of years ago, this was kind of one of those pin drop sessions where, we realized that systemic therapy could have such great intracranial response rates. And then importantly, right, really durable responses, which I think is what this updated 3-year outcome data shows us, as opposed to targeted therapy, which works well in the brain, but they progress quickly in the brain. So I think that this changed practice a few years ago.
So I personally think that this is tremendously outstanding data. I do want to highlight a couple of points though, and that is the inclusion criteria for 204 specified several brain metastases. So you couldn't have 30 or 40 lesions. You had to have up to 5 or 6 lesions. And the cutoff criteria was 5 millimeters up to 30 millimeters. So we still don't know what to do if you have more than 30 millimeters and if you have less than 5 millimeters of active intracranial disease. And the other important question is, what do you do if you have leptomeningeal disease, right? So all of these studies, the ABC trial, the 204 trial excluded patients with leptomeningeal disease. So the question of what to do in this setting of leptomeningeal disease is, at this point in time, still a very, very difficult, unanswered question. And I believe there are several trials at MD Anderson, for example, that are looking at this. Certainly a study led by Dr. Glitzer looking at intracranial, intrathecal NIVO, and I think at least a TIL trial as well. So there are, yes, again, lots of unanswered questions in this setting. Certainly want to highlight the fact that at least some of our colleagues are doing studies of combinations in BRAF mutant disease. So Zainab Aroglu has got SWOG S2000, a very appropriately named study, S2000, looking at IPI-NIVO versus ENCO, BINI plus NIVO in BRAF mutant untreated brain metastases. So lots of interesting data hopefully to come from that. patient population. So with that, I think we've covered quite a few of these abstracts that I think are fascinating, but we do want to answer some of the questions that have come through in the Q&A. So let's go to some of the questions that were asked and answered. So the first question, I think this is for Dr. Funchain, and that is, do you think a trial of PD-1 monotherapy in the control arm gives us enough questions, gives us enough answers to switch practice? So a very, very provocative question. And the question really is, do we need a CTLA-4 versus Nivo-Rela trial? And before you answer that, Pauline, thinking ahead to the Pivot-02 data that is likely to come forward in 2022. Do we need Ipi-Nivo trial against Nivo-Bempeg if that indeed ends up being positive? So really, what is the control arm for all these studies?
Right. I think the Nivo control arm is completely appropriate in terms of we know that Rela Nivo it just looks so much better than Nivo monotherapy. Now, would we like a CTLA-4 PD-1 versus Rela Nivo? Yes, we would. Is it going to happen? I doubt it. I doubt it. I see no party interested and rich enough to do that trial. So I don't think that would happen, although it would be nice to see. Now, yes, and then what happens with Pivot and Bempeg plus Nivo? That's a great question. And again, I mean, I think we would love to see, really, I think the control arm that we're looking for is CTLA-4 PD-1. However, I don't think at this point, we're going to get people interested in doing trials versus CTLA PD-1 unless they see numbers that look as good in terms of overall response rate. And certainly nobody's going to spend enough time to figure out their 5-year overall survival rate in order to go up against CTLA-4 PD-1. And I think the name of the game is now just to show off a decreased toxicity profile, right? And it becomes much more challenging too, as if you wanted to try to use CTLA-4 PD-1 as a control arm, are you using CTLA, IPI3 or IPI1? So I think it's going to get really messy in the next couple of years, and we're actually not going to have the data that we want.
Fantastic. Dr. McQuade, did you have a comment to that?
As far as whether we need a trial, I mean, I think it would be great. It would be, you know, I think it would be one of those trials that would need a co-primary endpoint of both response rate as well as toxicity. Again, whether that will ever happen is unclear. I don't think IPI is dead. I think that we still have a use for IPI even in the front line, especially for brain mets. And again, we need specific trials, and we will have them, of Nivo-Rela, you know, in that setting in particular.
So we have a question by an anonymous attendee regarding the lack of ORR data in relatively 047. So I think it's probably a good time to clarify that this was a study design question. And so Dr. Funchain, would you please clarify why we don't have ORR data in 047?
It's coming is what we hear.
Yeah, it's basically it's a hierarchical design in which the investigators, I think, chose to do a PFS primary endpoint. And so we'll have ORR at a later time point. So it's not like we don't have it, we just don't know it, which is, of course, a very, very fascinating setting to be in. Pivoting to stage 2 disease. So we're going to now be treating stage 2 melanoma and stage 2B and C melanoma, at least now with Pembro, potentially with Nivo. So Dr. McQuade, do you have a strong sense as to, you brought this up earlier, just to, you know, push on this controversial point of treat now or wait until you relapse and treat later?
Yeah.
What are your thoughts?
Yeah, again, I mean, it comes down to shared decision making, but you know, we do know from the patients in 054 that were kind of the treat later, their outcomes were pretty poor. Now, the question is, those might have been the patients that were going to relapse regardless. And so we know that you know, there's a large portion that we're over treating, and then there's patients that are going to recur regardless of what we do. And really where we need to go is understanding what are the biomarkers that help us differentiate who benefits from adjuvant therapy in both the stage 2 as well as the stage 3 setting.
And potentially a setting in which we'll also have some data from the neoadjuvant setting, because the pivotal trial that looked at neoadjuvant versus adjuvant SWOG S1404, led by Dr. Patel, it will be closing shortly, and will potentially be giving us a readout in the next 6 months as to whether adjuvant versus neoadjuvant is better. So lots of interesting things to come. So with that, I thank you for your participation and for the excellent discussion of these extraordinarily practice-changing abstracts. Very, very interesting data. Anybody who's a melanoma medical oncologist is certainly got lots to do, but is also now going to be extremely confused, because much like lung cancer, we're now going to have multiple regimens in the frontline setting, potentially multiple regimens in the frontline setting, and a great deal of discussion and not necessarily a great deal of clarity as to what to do. So with that, thank you to LARVOL for organizing this, and to my co-presenters for an excellent, stimulating discussion.
Thank you so much,
Thank
Dr.
you.
Davar, Dr. Funchain, and Dr. McQuade for your expertise tonight. I'm sure I can speak for the entire audience in saying we appreciate your time. We always learn so much from these educational discussions. To all our audience, thank you for joining us tonight. The replay of this discussion will be available on LARVOL's YouTube channel, and please join us for even more LARVOL clinical panel discussions following the upcoming SITC San Antonio Breast Cancer Conference and the ASH Conference in November and December. So I hope you have a great evening. Thank you again to our panelists and our audience, and have a great night.
Thank you.